So here is uh, the renal physiology part 2. It will be inshallah quick. So the determinants of urea creatinine levels, there are so many things. If you want to know them, just write MDRD, which is if you are muscular patient, male, you will have more creatinine because the degradation of the purine synthesis will result in urea and creatinine. So if you are a muscular patient, you will have more creatinine. If you are lean patient, you have less creatinine. If you have older, it must be low because your muscles is less and you have more fat. And if you these are some things that increase your urea level, just to take an idea. Why we rely more about creatinine for the function, not the urea? Because urea is easily affected by the dehydration and rehydration process of the patient. So if you are dehydrated for a little bit, urea will go faster and way before the creatinine goes up. So for the creatine to start to go up, you have to lose at least 50% of the nephrons that are currently functioning. So here, as we said, some things that increase the production of urea, and here are some things that reduces the production uh, of urea. And as well, you have to know with um, sickle cell disease, you must have less amount of creatinine to be considered normal, because normal creatinine for sickle cell patient mostly is not normal. So the GFR, glomerular filtration rate, as we said before, it is the to excrete the urine and to get rid of the toxic material. Here is to calculate it. Here is the formula to calculate uh, the estimated GFR. We actually use this MDRD. In real life, we just write MDRD in Google, and this will give us like a chart. You just put in the information about the age, ethnicity, weight, and creatinine number that the patient has, and will give you an estimate GFR to the patient. Okay, so the GFR is actually, we have different stages, 5 stages of GFR when we have kidney injury. So the first stage is 90 and above. You can have 90% and normal, which is considered normal. GFR of 90, 95 is normal. But when you have injury, this is called stage 1, uh, or this is the first stage of acute kidney injury. Second one is from 90 to 60. From 90 to 60, here is what we call stage 2. From 60 to 30, this is stage 3, and sometimes they divide it. Stage 3 is um, from 45 and to 60, this is stage 3A, and from 45 to 30, this is stage 3B. And from 30 to 15, this is stage 4, and less than 15, this is stage 5. And here, if the GFR is less than 60, um, there's more likely that uh, the hormonal part of the kidney will be affected. So less vitamin D, less production of, uh, um, um, let's say, um, blood RBC. And we are going to discuss this in a little bit. And serum creatinine only to estimate renal function. No, you cannot rely only, because as we said, there are many variants. Um, if the patient is very big, muscular, has a higher weight, and the ethnicity itself and the age itself will be affected by the amount of, and the consumption as well of creatinine will be affected, of protein will affect the creatinine, and so we cannot rely on it. So with aging, you would expect less amount of serum creatinine. So if the same amount of serum creatinine in 22, this is normal. In 6 years old, because he has less muscles, we expect it to be less. And in 8-year-old patient, the GFR will be less than the this is almost stage 3A, and he's at stage 2, and if he has a problem, so this is a stage 1. So endocrine function, we have the renin-angiotensin. We talked about this in the first lecture. We have the erythropoietin, which is responsible for the production of RBCs in the body. And we are going to discuss this. Vitamin D, uh, here is important things that the kidneys do. And we have the autocrine function, which is the prostaglandins that um, either dilate or constrict the afferent or efferent arteriole. Here there's the nitric oxide to only dilate the afferent or efferent arterioles. So we talked about the angiotensin-renin-aldosterone system. We are not going to talk about it again. Erythropoietin, this is a major stimulus for erythropoiesis. We have something called hypoxia induced factor 2, alpha and beta. Beta is always present. Alpha is always synthesized, but it is always degraded. Always something called the purine, um, uh, not purine, I think, yes, hydroxypurine. Uh, so once you have hypoxia, there is no oxygen, less oxygen. There is something called purine, that this purine will be oxidized. So oxidation of the purine needs oxygen. If there is no oxygen, there is no hydroxypurine being synthesized, because to convert purine to hydroxypurine, you need oxygen. This hydroxypurine will activate many enzymes to degrade the alpha subunit of hypoxia-induced factor 2. So if we have oxygen, we will not have the alpha subunit uh, uh, of hypoxia-induced factor. So if we don't have both of them, alpha and beta subunit, we cannot uh, induce erythropoiesis, and erythropoietin will not function. So once you have anemia, for example. So less oxygen goes to the purulin. The purulin will not get oxidization, will not cause hydroxypurulin, and will not activate the enzymes that degrade the alpha subunit. So you will have more alpha subunit in the system, and you already have beta subunit. Alpha and beta subunit will be formed, and this will produce goes to the bone and produce more RBCs. Vitamin D, as you know, the sun is needed for kinking one of the bounders in the cholecalciferol. Um, it's found in your skin. So the sun or the light of the sun do some kinking in this in this boundings. الروابط هذه تصيرها زي ما تقول بسبب أشعة الشمس تصير لفة فيها تسمح لها إنه يصير فيها hydroxylation. So الليفر will do 25 hydroxylation. يسوي الهيدروكسيليشن في السايت رقم 25 والكدني يسوي هيدروكسيليشن في سايت نمبر 1. So if someone has problem in his calcium and you give him vitamin D, the inactive form, he will not be it will not be sufficient because the kidney will not activate it. So we give them something called 1 alpha. So it has the hydroxylation in 1 alpha and will go to the liver to make the 25 hydroxylation and will be active vitamin D and will raise your calcium. So if someone with stage 5 kidney injury or stage 4 kidney injury and you give him the normal vitamin D, he will not increase his vitamin D and thus will not increase his calcium. And we said what is this prostaglandins and what is the function. And prostaglandins are actually inhibited by NSAIDs. So that's why if your kidney needs to dilate the afferent artery and you take NSAIDs and this process is not, the prostaglandins is not formed, this will harm the kidney and along with other things that can harm the kidney as well, but with long-standing NSAIDs is damaging to the kidney. Nitrous oxide, as we said, is to dilate the afferent arteries or afferent artery to maintain the pressure. And thank you.